And it became early in my career as a pulmonary and critical care physician, it became a emphasis, but a very small sidelight emphasis. And then a young man named Richard Burdell ended up on a ventilator with ALS, and he was the same age I was in 1987. So I was 37, 38, and he was maybe a year younger. I don't remember the exact age, but he was roughly my age and had a lot of same interests I had in various sports. And he was very charismatic, and he lived for 11 years on a ventilator. His sister coordinated his care with 24-hour-a-day caregivers with a tracheostomy and a ventilator. And his dying wish to his sister was, why don't you make a foundation, or please make a foundation in my name. He was a very public person, in my name, and make sure other patients with ALS get excellent care and find a cure. And so his sister, Cindy Burdell, came to me a few months after his death and asked me to be on the board of directors of this little foundation. And I was the first person she spoke to, and I said yes, not thinking it was going to go anywhere. But I'd spend some time with her and other people trying to figure out how to help people with ALS. And lo and behold, she was able to pull it off and develop the Richard Burdell Foundation for ALS, or the Richard Burdell ALS Foundation. And 3 or 4 years later, we joined the national organization, the ALS Association. At that time, they had a rule that you could not include a name in your title. They later changed that rule, but we haven't gone back. So we are the ALS Association of Oregon and Southwest Washington, but it started in the name of Richard Burdell. And I've been on the board ever since, and I've been on the board of trustees now for about 7 years. The local board has a rule that says you can only be on for 6 years, and then you have to go off for a year. But in one of the meetings when I was absent, they passed a rule that if you're also on the board of trustees, you can stay on as long as you're on the board of trustees. So that's how I've been able to be on the board of directors locally for 20-something years now. And I'm honored to do it. I've met so many inspiring people and wonderful people with ALS and their families and caregivers that I'm glad to give back. At this point in my career, I'm 71 years old, and for the last year and a half or so, I've only been seeing patients with ALS 1 day a week, most of it through the ALS Center at Providence, but some outside of that. And I decided at the end of this year, I will stop doing all the clinical work I do, but I will continue my volunteer work with the ALS and some other volunteer activities also. So that's basically a long story for you, but figured I'd give you the highlights. And Belinda?
Well, mine's not as long. I'm Belinda. I've been a respiratory therapist here at Northwest Medical for about 9 years. Our old CEO, Trina Bandaloo, she was also on the board of directors. So that's how we got invited to be able to be a part of this. I'm always honored to be able to do it. So last year we kind of missed out. So I'm happy to be back, even though this is all foreign to me. So yeah. Hi, everyone. That's all.
It's always nice to work with Belinda. And I should say that Northwest Medical was started by a gentleman named Jack Hopkins. And Jack and I met on a tennis court in the 1990s and became close friends. I think the world of Jack. He died a few years ago, but I think the world of him and his family. And he had the heart of gold for his employees and for patients with ALS, and he was a big contributor to the ALS community. And I think that's continued with people like Belinda in the organization. So either Belinda or her predecessors have always been the people who brought all the equipment here to show, demonstrating their commitment to the community of ALS. So I guess now's the time to start the real talk, the thing everyone's been waiting to hear. And I like to start, we've done this in person many, many times. I think once a year, Cassy. but I don't think we've ever done it virtually. So this is a unique trial. So I like to start at the beginning with ALS, anyways. And you all know that ALS most commonly starts in the feet or the arms, the extremities. You have a weak leg or a weak arm or a weak thumb or something, and you can't quite figure it out. And after many doctor visits, they say you have ALS. That's about 2/3 of people. That's the way it starts. About 1/3 of the people, it starts with what we call bulbar ALS, and that involves the bulb of the brain, which is the brain stem. It looks like a bulb, I guess like a flower bulb to old-fashioned pathologists who named these things. So it's called bulbar ALS. And those people, and again, it's about 1/3, have speech and swallow problems predominantly as the beginning. They have slurred speech or slow speech as the initial symptoms. So that accounts for almost everyone, but about 1% of people, the first thing they notice is breathing problems. And that's the most difficult to diagnose. And they end up seeing lung doctors like myself. And it's a hard diagnosis, but eventually something else happens and the diagnosis is made. But the reality is everyone with ALS gets everything. Everyone gets extremity weakness. Everyone gets bulbar involvement. Everyone gets breathing muscle weakness. And unfortunately, the breathing muscle weakness is what leads to death in almost everyone with ALS. It's the cause of death for most people. There's other things that can happen that contribute, but it's the breathing muscle weakness. It's the life-sustaining effect of ALS, unfortunately. And when I talk about the breathing muscles, there's really 3 groups. One group is the breathing in muscles. You got to take a deep breath in, and that is predominantly the diaphragm. The diaphragm is a big muscle. They're semicircular like this, and when they work, it's a diaphragm. There's 2 of them, one on the right, one on the left, obviously. When they activate to breathe in, they flatten out, they tighten up and flatten out like that. And that increases the volume inside the chest cavity, and that's where the lungs are. And something has to go into that volume in there, and it's air. You suck in air, and we literally suck in air. That's mainly the diaphragm. There's some muscles between the ribs that help the ribs move out and expand the ribs and that sort of thing, but mainly it's the diaphragm. So the diaphragm is the breathing in muscle. There's breathing out muscles, and normally breathing out, once you breathe in, the lungs like to collapse. They're like a balloon, and they just will automatically collapse. So if you breathe in, all you have to do is stop breathing in. It goes out because the lungs like to collapse. But if you want to force the air out, and mainly forcing the air out is necessary with extreme activity or coughing and sneezing. And coughing is a really important one. That's not the diaphragm that does that. It's the abdominal muscles. I can't show you here, but it's the muscles that people do to do sit-ups and crunches and their core and all that sort of stuff. Those are the cough muscles. If you think about it, when you cough, you take a deep breath in, but then to really force it out, tighten those belly muscles and cough. Now,
my apologies. I couldn't hear what you said.
Siri is trying to help me with something. Sorry, Siri. So she couldn't hear what I was saying. I'll take it off, and maybe she won't irritate me. So the breathing out muscles, mainly the core muscles, the abdominal muscles, and it's most necessary for cough. And we all have to cough. Every day we have a little mucus when we wake up in the morning. We go and out it comes. So those muscles are important for that. Or if you get anything down in your lungs and things go down the wrong pipe, that sort of thing can all happen. And then the third group of muscles that's important for ALS and breathing is the bulbar muscles. Actually, it's the coordination of the voice box that's real important for coughing. When we cough and we don't think about it, no one ever thinks about this sort of stuff, but you have to take a deep breath in. You have to close your voice box really tight. So you breathe in, and then you close your voice box, and you push out with those abdominal muscles, the core muscles, and then you suddenly open up that voice box, and you get a cough. And I'll imitate it here. So that's a good cough. Now, a bad cough in a patient with ALS is more like this, because they can't close that voice box tight, and they can't breathe in really deep, and they can't force out really strong. But really, it's the voice box is the biggest problem. So it's more like because that voice box is not totally closing, and you'll hear that occasionally when an ALS patient coughs. So that's a little of the background on the muscles. And then the next thing to talk about briefly is testing. And if you go to an ALS clinic in the non-COVID era, you will get all sorts of testing for your breathing muscles. And we're coming out of that era. Fortunately, you may have, if you're recent to ALS, you may have had some sort of screening tests, I'd say. But the tests require people to breathe out really, really hard predominantly. And the problem with that is if you have COVID, you're breathing out COVID really, really hard all over that room. So there's been limitations on that. You've had to go to special places instead of just in your ALS clinic. But the standard, the most common and most important test is probably called the forced vital capacity. And it's a test where you breathe in really deep and you blow it all out, and they measure how much you blow out. And it's called the forced vital capacity, or the formal name is spirometry. And it's done by a respiratory therapist. And most people know it as the blow, blow, blow test, because when you're blowing out, they're yelling and screaming at you to blow, 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 blow. And they keep telling you to blow, even when you know there's not a drop of air in your lungs, but they keep wanting that last drop out. And actually what they want is at least 6 seconds. And that can be very hard for an ALS patient. So that's the blow, blow, blow test. They also do a suck-in test, and that sort of narrows it down to the diaphragm, and that's easier to do in the COVID era. So you may have had a screening test with that in the clinic. And then there's a cough test that's also hard to do in the COVID era, because they literally ask you to cough into this little machine. So those are the three primary tests. They can do some blood tests. They can do some fancier tests. They could do an X-ray, all sorts of things. But that's sort of the background on the anatomy, the physiology, the pathology, the pathophysiology, and the testing that people go through. That's a lot of fancy words that we all learned in medical school, but it's basically the background of breathing in ALS for you. So, and then there's things we can do to help people with ALS, and Belinda's going to show us some of those things. And I don't know what you have up first. Bamboo bag? Great. So one of the things patients with ALS can't do is take a really deep breath. And if you can't take a really deep breath, you can't expand every part of your lung. And parts that aren't used will be wasted and eventually scar over and cause more problems. So Belinda's going to show you the first thing we do for many patients with ALS. And this is a simple bag that costs about $15. Yeah, I think you can buy them on Amazon, but I know many of the ALS clinics give them away. I don't know if the ALS Association has them or not. Do you have them, Cassy? No. Okay. So this is a simple thing that you might get at a clinic, and it helps prevent pneumonia and scarring in the lungs. Go ahead, Belinda.
Yes, so thank you. This is just an ambu bag, and it's hooked up to a mouthpiece right here. So what this is going to do is help with lung expansion. So we just put it in our mouth and we just push the bag, just squeeze it. Some people will put it underneath their arm and kind of do a chicken thing like that, just however you can pump up air into you. So if you put your mouth around it. So about 5 or 6 breaths, I'm pretty full. You just kind of passively exhale on your own and do a couple more, breaths like that. Just a couple times a day will really help with the lung expansion therapy. It's nice and portable, and you can take it places with you. So it's nice and light.
Yeah, Belinda is at a disadvantage on this virtual thing. Usually she uses Cassy or some other volunteer to be the subject of some of these machines, and she can talk while she's explaining how to do things. It's an easy, simple thing to do early in the diagnosis if there's any suspicion of weakness at all. And you can have your, if you have weak hands or whatever, you can have a caregiver do it for you. And most patients can do 5 or 6. You take a breath in and another breath. You don't let it out until you're fully in there. It's simple. And I think Cassy just put out some directions about it. I'd never seen that, Cassy. Good. Thank you. What's next, Belinda? I think I know, but go ahead. Oh, the famous suction machine.
Yeah. So the next thing is the suction machine. It's pretty lightweight, about 8 to 10 pounds is all. It's portable. It has an internal battery in here, and this is just to help get the secretions out of the mouth. So it has a little canister that the secretions will pool in. It's good to help with like brushing the teeth or anything like that. Just anything to help get all that stuff out of the mouth. And what you do is just have it all hooked up, and hopefully your DME company will show you how to use it. We do anyway. How the proper operation and troubleshooting of it with it is. But basically, you just turn it on, you put it in your mouth. It's just like a dentist. Like you just put your mouth around it, and it just gets all that saliva out of your mouth, just like a dentist would. And it's portable. You can take it places with you. It's got an internal battery, so.
Yeah, it's another piece of inexpensive equipment. If you have bulbar ALS, you might get it earlier. If you have extremity ALS, you might get it later. But they're really very inexpensive. There for medical equipment, we're talking, I don't know, $300, $400, something like that. I'm guessing. Belinda knows. In medical prices, we consider that very low. They are invaluable, and you can put that little sucker all the way back to your back teeth, or maybe even a little further, as long as it's not gagging you too much. So then, just like a toothbrush goes to your back teeth, and you can handle that. So it's perfectly safe. You can't hurt yourself with that by going too far back. I guess if you were malicious and going like this, it might hurt someone. But if you're just doing this sort of thing, it's fine. Good. I see something in the chat. I want to make sure I'm not missing any. Is that just Cassy? Yes, that's Cassy with a breast stacking guide. Belinda, what's next?
Okay, so up next we have our cough assist right here. The cough assist and suction we usually give out at the same time. With the cough assist, it's nice because you can do up to 3 different presets on this particular cough assist. So the first one, we would typically do a normal pressures set by the pulmonologists. The second preset, we would do just a little bit higher of pressures in case you have something thicker down there. You really need a little bit more assistance to get that out. And then the third preset we can actually do for breath stacking. So instead of using this ambu bag, we can just let the machine do it. So that part's nice. So I'll go through the regular cough assist and the breath stacking though with you guys. So we just turn it on here. Well, it would help if I plugged it in. 1 second. And when you're doing this with your, we show the caregivers on how to do it. It takes a little bit more coordination. You really need a good seal with this mask. You need to really press against the face so we get a good seal. And I tell my patients to exhale completely and then put the mask on because it's going to give you an inhale breath right away. So. All right. So that'd be one treatment. We just do about 4 to 5 breaths, give a couple, like 30 seconds of a pause, and then do 4 to 5 more breaths. And that's a typical treatment. And we want to do it in the morning and at night. I tell people in the morning after you wake up, kind of clear all those secretions out. And then before you go to bed, clear all those secretions out before you go to bed. And anytime you need to use it during the daytime, that is fine as well. And then just to get to my breath stacking is just a simple going to our settings, modifying it, pressing select. And then with the breath stacking, again, it's just going to keep giving me inhale breaths until I feel full. And then I just take the mask away and I exhale on my own. Again, exhale completely before you start. And then with the breath stacking on the machine, I can only do about 2 to 3 breaths before I feel full, as opposed to, 6 breaths on this thing. So you really are letting the machine work for you.
So those are all important things really to help you keep your lungs clean. And if you get a cold or a bronchitis or even a pneumonia or bordering on pneumonia, you might be using the cough assist every hour to clear out secretions if there's a lot of stuff down there. Or if God forbid you have other lung diseases like COPD, you might need to use it more often than twice a day, just to keep your lungs clear. But Belinda did a great job of demonstrating that. It's hard to talk while you're demonstrating that sort of thing. But, every time we do one of these things, I learn something after 30 plus years. I did not know that there were 2 settings available for the cough assist. You have your primary setting, and then you're sick and you need to clear more stuff out of there, and sort of secondary settings that are more powerful. So that's great. So thanks for instructing me about those things. The cough assist is really nice, and to have the mechanical breath stacking for some patients is invaluable, because that bag gets a little hard to use at times for patients, and they like the mechanical. Okay, what's next? Looks like an AVAPS machine.
We have the AVAPS units, the Dream Station ones still. So not sure what we're going to be doing with those, but we still have those in stock right now. I'm sure. Yeah. So with this one, AVAPS means average volume assured pressure support. Basically, it's like a little mini ventilator, and it's not portable. So it has a little water chamber in here that you'd want to refill for, so keep your humidity. It does have a heated tubing as well, so it helps create a little bit more adequate sense of humidity for the patients. But basically, it'll give you a volume, a breath rate, everything to help your respiratory muscles take a little bit of a break. So we want your respiratory muscles to be as strong as possible for as long as possible. And by using this machine for at least 4 hours, will really help benefit you with that. So I'm going to take off my headset real quickly.
For some people, this is a real lifesaver. It's a modification of CPAP. You may have heard of CPAP for sleep apnea. And this is just CPAP that's super smart, because it's got a bunch of little computer chips in it to make sure it's doing the breathing for you, so your diaphragm doesn't have to work. And a whole bunch of studies done in the late 90s and early 2000s showed that people who could use this for more than 4 hours a day lived significantly longer and significantly better than people who could not use it, with ALS specifically. And we have patients who literally have gone years living longer because of these machines. And I see there's a question in there. We will get to that very soon. So you can see she's using a mask that comes up to the nostrils, but also allows the mouth to be open, and air can go through the nostrils or into the mouth. And it's called I'm not sure what it's called nowadays.
DreamWear Full Face.
Okay. DreamWear Full Face. And there's all sorts of different masks, and your DME company will try and find one that fits you best, both in terms of the style and in terms of the size. But it's real important that it doesn't have a lot of leak. Now, it's got to have a little leak, because breathing out, you got to get the air out. But it doesn't. You don't want extra leak beyond that. If it seals well, there's no noise. You can see Belinda there. There's no noise. She turned on her microphone. You still don't hear any noise. They're very quiet, and we'll talk about why they're quiet in a minute. But this is a really important intervention for people. I always tell people, don't aim for 4 hours the first day. You got 90 days to prove you can use it for an average of 4 hours most of the time. I won't go through the details, but if you do that, then you basically will have the machine on rental for 13 months, and then you own it. What I usually tell people is just put the mask on at first without the machine. And you can breathe through the mask without the machine, and make sure you can do that for 5 or 10 minutes. And if that works, maybe the next day you hook it up with the machine and you sit there awake in the middle of the day and make sure you get used to breathing with it. And if that works well, maybe you lie down in your bed and try it during the day, the third day, and just relax. And if you can do that for 15, 20, 30 minutes, then you can try and sleep with it. But not everyone gets to sleep with it. Some people just don't sleep well with it, and they can use it during the day while they're watching TV or reading or whatever. But a lot of people get into it and sleep with it, and they get their 6, 7, 8 hours of sleep every night with it, and they don't need to use it during the day. So it's comfortable at night. And many people who have breathing muscle weakness is significant, where when they lie down, they have trouble breathing because they're working against gravity. They will find that they do great right off the bat with this, because it supplies the muscle that is so weak that they can't lie down and breathe. So it's a great machine. Now, I see in the chat, the first question is, I got an AVAPS machine 9 days ago. I heard there's a recall for this model. How do I see if mine's a recall? Well, let me talk about the recall, and Belinda might be able to know if yours is recalled or not. Respironics, which is I think the primary supplier in the United States, although there's another company called ResMed from Australia, which is a pretty close second. They're both great machines. They both make AVAPS. One of them calls it AVAPS, and one of them calls it IVAPS. So if you have a Respironics AVAPS machine, it may be on recall. Here's the story on the recall. To make these machines quiet, they have to have a polyurethane foam lining the plastic outer thing, so the vibrations from the motors inside don't get amplified by the plastic and everything else. Well, they discovered on quality assurance testing a couple of months ago that the foam in hot and humid weather or in some other conditions could either give off a gaseous compound or a particulate compound that could be irritating to the throat and airways. It's apparently extremely rare. 0.03% of patients have complained about that. Did you hear that? 0.03. So that's 3 in 10,000, I think, have complained about it. So there's no big concern there. But and I think it's unknown if that gaseous stuff could be carcinogenic. It might be. They've also said that if you use a product like SoClean, which uses ozone to clean the machine during the day, it might make it more likely that the little particles get out, or the I'm sorry about the background noise if you hear it. Is it a problem? Okay, someone's working outside there, but they'll be gone in a minute. But these SoClean machines that clean with ozone might make the particles come out, or the gas come out more likely. So everyone's told, don't use the SoClean machine. Clean your equipment by hand, the old-fashioned way, just with water or soap and water. Dry it well before you use it. The likelihood of this being a cancerous problem is close to zero, especially for patients with ALS. the general to tell you how unlikely this is to be a problem, the company has not been required to do any recall in Canada or Europe. Those agencies, our FDA equivalents, have not said you should recall this. But our FDA and Respiratory came to agreement that they would recall. And then what they're going to do is either replace the machines, maybe Belinda has some update on this, either replace it with a newer machine that doesn't have that foam in it and has something else, or a company like Northwest Medical works with ResMed, the other company. They may be supplying more of those machines, or the new machines. The newest machines are okay, but it depends when they were manufactured. Anything manufactured from April something back 5 years has the old foam in it. So I think it was Bruce who was asking about this. If you have a machine that was manufactured after April, and you only got it 9 days ago, so maybe you're lucky, you're okay. But the recommendation is if you're using this machine as a life elongating or life sustaining machine, and not just for simple sleep apnea and snoring, it's recommended you continue to use it and talk to your supplier about whether you need a new machine or a different machine, or just wait the month or 2 or 3 to get the foam replaced. Is that what you're hearing, Belinda?
Yeah, we've been telling people to speak with their doctors and see what they recommend, if they want them to continue using it or not. And then, like the chat room says, put in your serial numbers, contact Respironics itself. They'll take down your information. For the Trilogy units, it's recommended to keep using that bacteria filter in place. And then for the Dream Stations P series, 60 series, anything like that, again, put in your serial number, and we're still in the waiting period on that one.
I see a question from Christina. Can an ALS patient do the breath stacking setting themselves on the cough assist, or does a respiratory therapist need to set this up? But Belinda, on the cough assist, we give you some settings, I think, but it's really pretty simple. I bet you frequently get the prescription without settings for the breath stacking. Is that right?
Yeah, we get the titrate to comfort.
Yeah.
Yeah. So it's really easy, though. I mean, you would want to only use inhale pressures. You want to zero any exhale pressures, zero any of the exhale time. I do about a positive 22 for an inhale pressure for 0.6 seconds, and maybe a 0.2 pause. So it just stacks one right on top of the other. No room for exhale until you take that mask away. That's how we would do it. Your DME company should be able to help you guys set that up if needed.
I also see a question from Janet. I have a Voxen. It isn't as quiet as the one she has. Well, frankly, I think this virtual visit makes things quieter in the background. There is some noise from the AVAPs. I think the AVAPs, and we're going to show the Voxen. We'll tell you what the Voxen is in a minute. But I think the Voxen's a little noisier than the AVAPs, but not much. But it's got some other advantages and disadvantages. We'll talk about that. Did I miss any questions? Where's the chat?
I don't think so.
I think we're caught up. Yep. Good. So I think AVAPs is one of the most important things you can do, whether it's with an AVAPs machine that's called AVAPs, or an IVAPs, or a Voxen, or a Trilogy, or a Evo, or whatever else there is out there. Having a machine do breathing for you for at least 4 hours a day prolongs life. And frankly, it produces comfort at a later point in the ALS journey. When people are short of breath during the day, they can put it on and use it during the day. And we have many, many patients who use it 23 plus hours a day. meaning they're dependent on it for breathing, through their mouth and nose, not through a hole in the neck or any of that stuff. So it is a comfort measure near the end. It extends life, and then it's a comfort measure near the end of life, if need be. Belinda looks to have a Trilogy sitting up there. Is that a Trilogy Evo or is that a Trilogy?
Just the Trilogy 100.
Okay.
Yeah, we do have the Evo though, but this is just the more common Trilogy 100. This one can do dual prescription. So what that means is it can do your AVAP settings that you do for nighttime, and it can do a sip and puff as well. So it's really good to, again, for lung expansion therapy when you're just talking to some like people and you get a little bit winded. It's good to just take a big puff of air. So this machine will do that as well for you. And it's also got a battery life, so it gives you about 4 to 6 hours of battery, so you don't have to be tethered to the wall all the time. So it gives you a little bit more freedom. So this is a nice one.
Yeah, its advantage is the battery and the flexibility to do other things. It can do invasive ventilation, meaning tracheostomy through a hole in the windpipe. It does have that battery life. Its disadvantage is it's a little bigger, I guess, but that's because it's got batteries in it, so it is portable. It's great if you need to use a ventilator, whether it's an AVAP setting or something else, on a wheelchair, a powered wheelchair, while you're moving around. This is the most common machine to use. So it's we're talking about 3 machines that do similar things, but maybe some have some add-on advantages. The simplest is the AVAPs. I consider it a Cadillac. The next one up the line is a Trilogy. I consider it a Mercedes. And then there's a Voxton. I guess that's a Ferrari or something. I don't know. But it's not necessarily the sleekest. I'm not talking about power and sleekness. I'm talking about the number of things it can do. The AVAP just does AVAPs, and it just does it if it's plugged in. The Trilogy can do this sip and puff, which she's demonstrating right now, which patients sometimes are able to do during the day, especially if they don't have too much bulbar involvement. And we have patients who are dependent on this sip and puff to breathe all the time. They literally take a breath every 5 or 10 seconds. They have a straw usually sitting there or a mouthpiece like that right next to their mouth on a wheelchair on an arm, and they just put their mouth over there and take a breath every 5 to 10 seconds. So that's the Trilogy. That's our Mercedes, I guess, if you consider Mercedes a touch above a Cadillac. There's no Pintos here. You can be happy. Pintos or what was that Russian car? Started with a Y. I don't remember the name.
That was a Yugo.
Yugo. Was it a Yugo? And this is a Voxton, I believe. So Belinda, I'll tell them what a Voxton is, and you can sort of demonstrate it or whatever you want to do with it. Voxton is the newest guy on the block, made by a company up in Seattle. The company's called Ventec, and I have to disclose that I'm a expert advisor, clinician for that company. It's an unpaid position. I've never gotten anything except one dinner when I went up there for a meeting. And it was a good dinner, I'll be honest. I mean, not over the top, but a good dinner, and a tour of their factory. And me and a number of other pulmonary and critical care physicians who have a special interest in neuromuscular diseases are on their advisory board, but we are not paid. So the Voxton is a sort of a unique machine. Voxton stands for 5 things, the 5 letters. V is ventilator, so it can do AVAPs and everything else a Trilogy can do in terms of ventilation, including that sip and puff thing. O stands for oxygen concentrator, so it can give you oxygen. Most patients with ALS do not need oxygen, so that's not necessarily needed, but it does supply oxygen if you need it. VOC. C is a cough assist machine, and it can do it through the exact same equipment that you use for your ventilator, for your AVAPs. S is for suction, and it's a very good suction machine. It's more powerful than what she showed you before, and it's quieter than what she showed you before. And then N is a nebulizer. A nebulizer is a little machine that takes a liquid medication and makes it into mist that you breathe in. You've probably seen asthma patients use this, or COPD patients use it, where they breathe in a medicine. And occasionally we use that for patients with ALS, either to break up mucus, or because they do have asthma, or because it helps their breathing one way or another. But almost every patient with ALS needs the ventilator, the suction, and the cough assist. So they need 3 of the 5. And that's sort of the determining factor if you need that, and versus just needing an AVAPS machine or the Trilogy machine. It's a new machine, and there's a limitation on that, in that many of the DME companies are not comfortable with it. I think there's some reimbursement issues that are difficult for the DME companies to get around. I know Northwest Medical is accommodated themselves to this new machine. I think they're comfortable with it and are supplying it to patients when they need it, when they qualify for it. And we're recommending it more and more as time has gone on. So that's the background on it. Maybe you can tell us more about it, Belinda. I've prescribed it, in spite of being on their expert panel. I've prescribed it probably only 2 or 3 times. But I think I'll be prescribing it more until I retire in December. We're just learning in the clinics about which patients are best and how to get around the insurance issues, etc.
Yeah, the insurance is the caveat there. So if you get the suction or the cough assist and it caps out, insurance will only pay for one of those every 5 years. So by the time you're needing the ventilator portion of it, then you're already capped out on those 2 services. So the Voxen is... you're probably going to get a Trilogy on that one. It is nice. It is a little bit heavier. It has extra battery life, though. It gives you 9 hours of battery life with this one. Like Dr. Libby said, it has a really powerful suction. It's got a hospital-grade suction on here. So it's a 3-motor system. The cough assist works really well. The breath stacking, it doesn't do as well as the T70 cough assist does, but it still will do a breath stacking mode. The other thing is say you're just needing a suction and you're not needing your AVAPS unit at the moment. It takes literally, I timed it 35 seconds in order to turn the machine on, go through the warm up in order to get to that suction. And so if you're really needing that suction at that moment, you're waiting 30 seconds, and that can seem like a lifetime. So that's a downfall of this machine too.
Great. I see a question from Christina. We have 2 Christinas on the call. But the question from this Christina is, should PLS patients be using AVAPs? PLS is a close relative to ALS, and I'm not a neurologist, and I can't differentiate the 2, but I can tell you in general, PLS involves the extremities much more than the bulbar and respiratory system. It tends to be much slower progressive. For that reason, many patients with PLS will be diagnosed and not need an AVAPS for a long, long time. If you're getting the breathing tests and have no breathing symptoms, and the breathing tests look good, you may not qualify or need an AVAPS. To qualify for an AVAPS machine of any type, whether it's AVAPS, Trilogy, Voxen, IVAPS, the machines that you want to use for 4 hours or more at night, which I think is probably the most important intervention we do from a respiratory point of view. you have to have documentation of weak breathing muscles. And usually that's the forced vital capacity test is under 50%, which is terrible. Or your suck-in test is not as good as minus 60. Minus 60 to minus 90 to minus 100 is sort of normal. But if you're minus 59, which is pretty close to normal, you qualify for an AVAPS machine, an IVAPS machine, or a Trilogy, depending what other things you need at that point. Or there's rare patients where we qualify them based on other parameters. But those are the two standard tests that qualify you for AVAPS. And I've seen many PLS patients who were 4 or 5 or 6 years into their disease before I met them because they had no breathing issues and their breathing tests kept going being normal. So, and finally they met me because it was iffy or something. So I hope that helped you, Christina. I still probably recommend, especially if you have mobility issues, considering breath stacking, for example, because you probably don't get enough exercise to really expand the lungs. And if it's not with a bag and they tell you your breathing numbers are perfectly normal, you could do it yourself. Just take 5 really deep breaths a couple times, 3 times a day, something like that, or do yoga breathing, those sorts of things. PLS is different than ALS because it is different at a slower onset. Let's see. Is there other equipment? Are we at the end of the equipment ball game? I think we're at the end of the equipment ball game.
That's all my little toys I brought you.
Right. Yeah, Belinda that has all the toys and knows how to use the toys. And if you think your pulmonologist knows how to use the toys, you're probably wrong. I don't know any pulmonologist who has really close understanding of all these pieces of equipment and how to set them up and how to change them. I can fiddle around with them, and I occasionally will make some adjustments and send my adjustments in to Belinda or the Northwest Medical or whoever is the DME. But most of the physicians don't know how to adjust these machines. It's like any other piece of computer equipment. You got to use it a lot to be comfortable with it. And they all have computers in them, or at least a chip. I won't say a computer, but they all have chips in them. And they're menu driven, and there's all sorts of things you can adjust. And actually, I've got a couple patients who adjust their own stuff, but they're very smart, and you can look the manuals up online. They're all open access, so you can do that. The only other thing I would recommend is everyone should get a flu shot every year, especially ALS patients. I'm a big believer in COVID. If you haven't gotten it, I'd talk to your physician about it. There may be a rare patient who should not get it, but almost all of us should get it. Both as for our protection or the protection of ALS patients we see or care for, unless you've got a good reason not to get it. And there are some good reasons not to get it, but they're pretty uncommon. And it's amazingly effective. And it's yes, there are some side effects, but those side effects are generally 24 or 48 hours. And if you get COVID, it's probably at least a week or two. And if you end up in the hospital, it might be 3 or 4 weeks. And if you're unlucky, it might be a long hauler or die from it. And with ALS, you're at high risk. I think there's some interesting little chat stuff going on here. Let's see. We'll start with the fun ones, I think. Don't you think your Niners are going to need some mechanical breathing devices this year? Well, yes, you noticed over my head a 49ers helmet. And if you look at my personal email address, it's loulibby49@gmail.com. But I got that before I became a 49er fan. I was born in 1949. So that's the other 49 connection. but I am a 49ers fan. And I'm a 49ers fan because my middle son worked for them for 10 years. He was their data analyst, sort of like in, what was the name of that movie and that book? Moneyball. Moneyball was the Oakland baseball team hiring people who could look at statistics and figure out who would be a good baseball player and who would not be. And not just the scout saying, "Oh yeah, that guy's got a great arm," or "This guy's got great running," and "This guy's his fielding is great," and "This guy's blah blah blah." They just sort of looked at him and had an idea. They decided they would use statistics, and that's what my son was hired to do. And he did a lot more of that than that for the 49ers for 10 years. He reported to the general manager and the president of operations and even the owner, and did all sorts of fun jobs. So I became a fan, and he brought me down to a bunch of games and got to be on the field and even got to the Super Bowl with him, which they lost. So it was a fun run for 10 years. And then he left, for you 49er fan out there, he left when Chip Kelly was there and was leaving. And he was sort of part of the Harbaugh era. And teams have these eras, so he was part of the Harbaugh group, and he stayed after that for a couple of years. But it was clear the Harbaugh people were on the outs, and they had other people on the in. And so the president, who was a Harbaugh guy, and the owner, who was a fan of my son, helped him get a job in a startup, and he's done great there too. But we are still 49ers fans. So a lot of talk about something that doesn't have much to do with breathing, but you're right. But yes, the 49ers have tried to do something really unique, and that is to get a young quarterback while you have a quarterback you're paying $30 million a year to. So we'll see what happens with that. They're going to need some help. I'm not sure mechanical breathing device help, but they're going to need some help this year. But I'm still hopeful. A more relevant question from Janet: should you use a cough assist every day? Well, if you have a cough assist, we recommend you use it every day because you can do the breath stacking through it. If you think you have a good cough and you're told that you have a good cough, maybe you just do the breath stacking through it. If your cough numbers are good. And just use the cough assist if you're having trouble coughing, like if you get a bronchitis or something. But most people, we think, if they have any issue with their cough numbers, should use it every day, probably twice a day to help prevent pneumonia. All this equipment, I'll be honest, it's not, if you aren't using it, you aren't alone. Okay, I do believe every patient with ALS has the option to decide what they want and what they don't want, and that includes everything from invasive ventilation with a tracheostomy, which most people don't want, and I'm not a big fan of. It's a unique situation if you want that, to the cough assist and the breath stacking. If you hate it, if you can't accommodate to it, and I'd say even the AVAPs, the thing I'm the biggest fan of, 20 or 30% of patients never really adapt to it, even, and can't do the 4 hours. And Belinda, I don't know what your experience is there, but there's a significant group of patients who can't adapt to that stuff, and it's not their fault. It's difficult stuff to adapt to, and I don't blame anyone who says, "I hate that mask thing. I can't use it 4 hours a day." It's not like appendicitis, where if you don't have the surgery, you're going to die from it. And if you have the surgery, you're going to live. It's not cut and dry like that. You're going to live more months, not more decades, by using more months and maybe years, but not decades, because you use the AVAPs. Don't feel terrible if you can't use it. And I'll be honest, if you have significant bulbar involvement, it's harder to use all this equipment with the masks. It's much harder. So even a lower percentage of those patients adapt to it. Belinda, any reinforcement there or comments?
No. Like you said earlier, I mean, just try to, if you're having a hard time with it, try to wear it during the daytime as much as you can. Watch TV, read a book, associate something pleasant-ish with it while you're just trying to get used to breathing with it. Again, it's not going to feel natural. You're going to have to work with it. It's not going to work with you. And then, again, reach out to your DME company if you, again, titrate to comfort if you feel like those pressures are too high, if you want different types of masks. We have patients that use like a nasal type of mask during the day and then a full face at night, and just alternates. It helps reduce pressure points as well. So any way we can make it as tolerable as possible, we really want to do that.
Belinda, is it still accurate? Sorry, this is Cassy. Is it still accurate that most insurances will cover a new mask is it 3 months or 5 months?
It's every 3 months you'll get a new mask. Most DME companies like us, we have a 30-day mask guarantee though. So if you get set up with one mask and you're not tolerating it, you have the 30 days to find something new. That was thing with Trilogy. If you're using a Trilogy, you can get a new mask basically every month if you absolutely need it, because it's all included in that big old price of that ventilator. So but if you're just on a regular AVAPS machine, insurance will only cover one mask every 3 months.
Christina asked if I will be at the ALS clinic at Providence on October 4th. And I just looked at my schedule. I was scheduled to be on a New England vacation that week. My wife and I were going to go to New England with another couple. But that has been canceled. It's so busy in New England, we couldn't get what we wanted there, so we've delayed that a year. And I think there's a chance I will be there even though right now I'm not on the schedule. If I'm not at ALS clinic, usually one of my partners is there. And I'm not sure if one of my partners will be there. I have 3 partners who go to ALS clinic if I'm not there. If there's no pulmonologist there, almost always starting in July, there will be a respiratory therapist there, and they will do the testing, and they can advise on a lot of these things. In fact, if you look around the country at all the certified treatment centers of excellence, then there's about 75 of them. There's only about 10 that have a pulmonologist that go, but all are required to have a consulting pulmonologist, so you can be referred to a pulmonologist who doesn't come to the clinic, and all of them are required to have a respiratory therapist at the clinic. Now, that changed during COVID, but it'll come back to that eventually. So the respiratory therapist is really more important than the pulmonologist because they do the testing. And based on the testing, they and the neurologist can recommend many of these treatments that Belinda does. And I forget, Belinda, are you a respiratory therapist?
Yes, I am.
Yeah, okay, so Belinda's a respiratory therapist. Some of the people who work in Belinda's position are sleep technologists, and they evolve with all this equipment. But Belinda's a respiratory therapist and I don't know if you ever did sleep technology or not. Did you ever? No, she never did sleep tests. Sleep technologists do the nighttime sleep testing, and many of them end up in positions like Belinda, helping patients adapt to their CPAPs and BiPAPs and things like that. But that's a good question. And when I retire, and if I'm not there and you want to see me, especially if you don't see another pulmonologist, the folks at the clinic, Lauren and Ashley specifically, the 2 nurses who coordinate the clinic, can arrange an appointment with me either virtually or in my office out at the Oregon Clinic. So I'm glad to see you.
We'll never let you leave, Dr. Libby. And that is so true. There are several other local clinics that do have that are certified or recognized that do have pulmonologists on the team. Kaiser is one of those teams, as Dr. Wardwell. But OHSU doesn't have a pulmonologist on the team. They have a respiratory therapist, but they do have someone that they work very closely with to refer out to. So what,
the person that
what we're
The person they refer to at OHSU is very good. I've had many conversations with her. She's much younger than me, but she was trained by the person I consider one of the top two pulmonologists in the country for this type of treatment. Um, she's great. And then there's a guy at the VA who I know very well, John Mastronardi. And I don't know if he comes to clinic or not, Cassy. Does he come to clinic?
Does.
Yeah, I
He
thought
does.
he did. Yeah.
Yep.
And he's really smart and really good. And he knows this stuff too. He has a background in sleep medicine as well as pulmonary. So it's a good combination.
Well, we are very spoiled to have you, Dr. Libby, on the Providence team, but also just to be a part of these conversations and help answer questions. There's a lot out there, and I think just you talking with the community, both of you, just helps demystify some of the questions. One thing I'm going to do is put in the chat. I did put the breath stacking guide earlier up in the chat if you didn't get a chance to see that, as well as some information about the Philips Respironics recall that you can kind of take a look at. But I'm also going to put in the chat, some of you may have already seen this, but there were some really great respiratory health videos that were made by our national organization that feature several of the providers from the Providence ALS Center, including Dr. Libby, which I think are really, really well done, not only because they're focusing on respiratory health, a lot of the things that we talked about today, but also from kind of a nurse perspective. They have a dietitian who talks about nutrition and the impact on breathing, and just a little bit more of a holistic kind of view. So I'll put that in the chat.
It's really a nice. It's an easy thing to watch. It's an ALS patient, and he's a professor at Davidson University, a professor of political science, and he has ALS. I think it's slowly progressive. I'm not his physician, but he has ALS. It's mainly a foot problem, and he's very smart and he's very insightful. And he just interviews me and many other people in little 10 to 15 minute videos that were put together. The ALS Association got a grant to do this, and the grant allowed them to do it very, very professionally, to the point that they had multiple cameras on me, multiple cameras on him at the same time. They had people who were putting makeup on me, so I didn't have this little reflection up here on my head, that sort of on my nose. They fixed my glasses, and all the lighting is just perfect. So it was really a unique experience, and it was just like a conversation. And it came out really good. And little 15-minute things, and I think there's 5 or 6 of them. And Belinda, I forget if you were in that or not. Were you in that?
I was. Hopefully you edited me out, maybe.
Yeah. No, you're in there. I don't know. Did you come over to the Oregon Clinic to do that? Yeah.
Yeah, they had to put more makeup on me, and it was, oh my goodness, it was nerve-wracking.
Yeah. But he made it pretty easy. You sit there and talk like we're talking now, really. And it was fun. And he talked to a couple patients also, if I remember right. Donnie was one of them, wasn't it?
Yep.
And, yeah, he talked to a couple patients. So you get a great view of a lot of different things by watching that. And they're all 10 or 15 minutes. There's some overlap with what we talked about today, but it wasn't as structured as today. It was just a conversation.
Yeah. Well, there was a question, and Bruce, thank you for reminding me to bring this back up. A question that I get often from people is, will using AVAPs or BiPAP kind of make a person dependent, or are there kind of downsides to using non-invasive ventilation? Especially considering the word ventilator. I'm wondering if you'd talk about that.
Sure. No, there's no dependence on these machines that is caused by using the machines too much. We don't prescribe them until there's a reason to prescribe them. But even if you started them, even if I started it today with, I think, normal breathing muscles and normal lungs, and I used it 8 or 10 hours every night in my sleep, I would not become dependent on it because of that. I would not weaken my muscles because of that. But the reality is, by the time we can detect breathing muscle weakness in you, either by symptoms or by those tests we do, which theoretically detect the weakness before you might feel it, you probably have lost 40 or 50% of the nerves going to the diaphragm by the time we can detect anything. Because just like most of the systems in our body, we have more than we need normally. But if you get down to the 40 or 50% detriment, the rest of the muscle mass has to really overwork. And any muscle you overwork gets weaker faster. And if you can rest muscles after exercising them, they recover. Just like if you're going to train for a marathon, you would have days that you do hard workouts and days you do no workout or very light workouts. And of course, at the end, you taper off, so you don't do any hard workouts, for a week or 10 days or 2 weeks or whatever it is before a marathon. And it's similar for the diaphragm. You have the four hours where you rest and then you work. Unfortunately, we can't stop that work unless you need it more than the 8 hours a night. Was there another question there? Great. Glad to help.
Yeah. I don't see any other questions in the chat, but
I'm
sorry, there is one more that just came in from Ryan. What are the challenges of treating pain with opioids and breathing? And how does the use of mechanical devices impact it? It's a really good question.
It's a really good question.
Oh.
Opioids are narcotics. Fentanyl, methadone, morphine, heroin are all narcotics. Vicodin, oxycodone, all the terrible drugs you've heard about in the last 10 or 20 years are opioids. And they are wonderful, wonderful medications when you need them. Unfortunately, we have for a variety of reasons, had a massive addiction tragedy with them. But if you are in a car accident and you have multiple broken bones or major surgery, opioids are wonderful for getting over that pain for the first few days or first few weeks. And the careful physicians now know how to make sure that it doesn't become chronic. But ALS is different. If you have chronic pain related to ALS, and ALS itself doesn't usually cause pain, it's other aspects of ALS that cause the pain because you are unable to move and unable to get in positions you like. You lose muscle, so your bones are exposed to pressure that they wouldn't be because they were covered with muscle. You used to have an inch of muscle over that hip bone. Now you got a little skinny nothing muscle over that bone. So you might have some chronic pain from it. Or the muscles protect joints. Shoulders have muscles that protect it, and maybe those muscles are so weak you now have a torn rotator cuff and it's painful, and you're on opioids appropriately for that. Opioids depress the breathing center. So and opioids are used at the end of life to make breathing comfortable, to take away the sensation that you are gasping for breath, and they do that very, very well, just like they take away pain very, very well. At the end of life, if that's the goal is comfort, because we know you have days or weeks or a month or two to live. We put up with that. if it's earlier in the whole game, and you and your doctor are thinking you still got a couple of years or more left, and you're using opioids, we can adjust the breathing devices to make sure the opioids do not suppress your breathing so much that it's dangerous. But it's a more of a balancing act. It can be done. The smart machines like the AVAPs, the Trilogy, and the Voxen have alarms to make sure you breathe the way the doctor wants you to breathe. The Trilogy and the Voxen have very advanced alarms. They have backup rates, so if you forget to breathe, you get 8 breaths per minute or 10 breaths per minute or 12, a safe number. So even if the opioids suppress your brain to breathe, the machine will breathe for you. Yes, in that situation, you probably need the Trilogy or the Voxen, not the AVAPs. The AVAPs is not quite as, in my opinion, and you can tell me if I'm wrong, Belinda, but in that situation, if you're really worried about under breathing because of opioids, I'd favor the Trilogy or the Voxen. Is that right? Yeah.
Yes. Yeah.
That's a complex situation. And sometimes if you're just on, let's say you're just on Vicodin and a few of them a day, it's not a big deal. It's probably not a worry in that situation. But if you're on high doses of oxycodone or morphine, methadone, we worry a lot more about it.
Right. Good question, Ryan. Thank you. Yep. I think those are the questions that are in the chat, but I want to open it up. If there are other questions that are on folks' minds while we have Dr. Libby and Belinda on the call. And if not, that's okay too. You're always welcome to send anything that you think of to me afterwards, and I can filter it along and get answers for you all. All right. Well, unless there's anything else, I want to just say thank you to Belinda for taking time out of your day, and Dr. Libby to come and talk with us. This was very, very informational. I've sat through numbers of support groups and talks from you both, and I do learn something new every single time, and really, really appreciate it. So thank you, and thanks to everybody for jumping on the call today. Just a reminder, we'll send an email out generally a week before, but our next call like this will occur on July 28th. And the topic is going to be around power mobility. And we're going to be joined by Chris Lathrop, who is an assistive technology professional, ATP, through Norco over in Central Oregon, and works with Christina, Riddock, who's on our call today. So we're excited to be joined by him. So bring some good questions, and we'll see you all then. All right. Thanks, everybody. Have a great afternoon.
Bye-bye.
Bye-bye.
Bye. Thank you.
Thanks all.